Sorry, I unmuted our mics. Okay, I'm gonna sign off because it's almost ready
Don't-
to, what, no,
Yeah, like you can keep that window open, it's not gonna hurt anybody.
no, not that,
You're good to go anytime.
I mean our call, so we're not chatting.
Okay. Okay, you're all good to go there, it looks like it's live.
Okay, perfect, bye. So when you start, date, time, introduce yourselves and the presentation.
Hi, my name's Shannon MacPhee. I'm a pediatric emergency physician from the IWK, and I work with a program called TREC, or Translating Emergency Knowledge for Kids, which is a knowledge mobilization program aimed at getting the best possible care for kids. And it is October 23rd, 2019, and today we'll be discussing the new diabetic ketoacidosis protocol for children in Nova Scotia.
And my name is Krystal Forrest. I'm a registered nurse with the IWK Emergency Department, and I'm also working with TREC and a co-lead with Shannon MacPhee for this presentation on DKA.
We don't have any conflicts of interest to disclose, and in terms of the learning objectives by the end of this session, we'll talk about new evidence from a trial called FLUID, supporting more aggressive but controlled fluid management in pediatric DKA. We're going to go over some practical tips for looking after that kid in your emerge department with DKA. And we'll specifically talk about a new pre-printed order set and protocol that's available all over the Nova Scotia Health Authority. So just starting with the basics, diabetic ketoacidosis is a common complication of type 1 diabetes. And it is the leading cause of morbidity and mortality in pediatric type 1 diabetes. We see a fair amount of DKA as the initial presentation of type 1 diabetes. And so some of these kids can go unrecognized for long periods of time in their home, and they don't present to medical care until they're actually in DKA. Risk factors for DKA are poor control. And if you've had one episode of DKA, you're more likely than other children to come back. We do see it a lot in children, especially during adolescence, where they may be denying the presence of their diabetes, or they may be using lack of insulin control to control their weight. And we certainly see more DKA in children who are in difficult psychosocial situations or who have other psychiatric disorders. One of the things that we know about DKA is about 40% of children with a new diagnosis actually visited a physician 2 weeks prior to the diagnosis. And unfortunately for those kids, the DKA was not recognized, and they were sent home with diagnoses such as gastroenteritis. They may have been diagnosed with a UTI, and that diagnosis was wrong, and they eventually got sicker and came into medical care with the real diagnosis. We know that's a lot more common in really young children and toddlers, so especially those kids under 3. It seems to be off the radar for many people. And so one of the big messages today is to be alert. Be alert and be looking for that diagnosis of diabetes, especially in very young children. So there are going to be lots of people that come to your emerge department with diabetes that may have a high blood sugar. The purpose of this protocol is not for those guys. We only want to include those patients who are actually in DKA. And for that, you need 3 things. So your pH has to be less than 7.3. You have to have ketones, and you have to have either known diabetes or a random blood glucose more than 11.1. So you need all of those 3 things to be diagnosed with DKA and to move forward with this protocol. It's always important with that kid in front of you to understand how severe the illness is. And we always say it's as easy as 1, 2, 3. You know your patient has severe DKA if the pH is less than 7.1. They are moderate if they're less than 7.2. And the DKA is mild if they are less than 7.3. And I think those decisions are really important. They're important in the emerge department because it helps you understand whether you need to access life flight, for example, to be transported back to the IWK, or whether they're appropriate for management within your own hospital. And so those factors are really important. I think there's always a low threshold for calling LifeFlight or transferring to a tertiary care center if you think your patient is sick And so at any of the ranges, but certainly if the pH is less than 7.1, that should be a clue to you that you need help fast from one of the pediatric intensivists.
So just some clinical signs of DKA, just for all the triage nurses out there. Obviously, any patient with known diabetes and they have any fluid loss, whether it's vomiting or diarrhea, those guys are obviously at risk. Some dehydration, so dry lips, sticky tongue, tachycardia, tachypnea, small respirations, ketotic breath, abdominal pain. And when we talk about that population of young kids that are, a little bit harder to pick up on, and we got to think of like the 1 to 3 year olds for diabetes, just thinking altered level of consciousness, frequent thirst, frequent urination, those guys are, at risk as well. And we're really, really going to push this confusion, altered level of consciousness and drowsiness in our pediatric population as a clinical sign and crucial assessment skill.
Diabetes in kids is still a fatal illness, and we know from data from the 1990s that in Ontario there was 1 pediatric death per year. So it's something that still happens. Most of those deaths are associated with cerebral injury, which is the new term for cerebral edema, and that occurs in up to 1% of cases. I think what makes pediatric DKA different is that cerebral injury almost never happens in adults. It is a pediatric phenomenon, and so you're going to hear us talking a lot about cerebral edema and cerebral injury today because it's very specific to pediatrics and it is associated with mortality. So over the next few slides, we'll talk a little bit about the history of cerebral injury and why we've been so cautious about fluids in pediatric DKA. So there were a number of case reports from the 1980s that said, hey, the highest risk for cerebral injury seems to be if they received a lot of fluid.
Attention please, the Critical Care Series education session is starting at 12 noon in the Emerge classroom. Thank you.
So really high risk of cerebral edema if they were given a lot of fluid in those first 4 hours. And so what we used to think is that healthcare providers providing rapid fluid infusions to this population led to osmotic shifts, led to increased ICP and cerebral edema. And we focused on that for a number of years, and you can see over the last few decades we had very significantly restricted the use of fluids in peds DKA. But guess what? The rate of cerebral edema was 1% back in the 60s and 70s, and today it's still the same. And so even though we changed our management, it didn't seem to make a huge amount of difference. So we started to question this, and one of the first clues was that cerebral injury has been well documented to occur before healthcare providers are involved. And so we can see evidence at the door of our Emerge department for some of these kids having cerebral injury. So that started really to make us question what was happening here. We also started to have more information from animal studies that there was cerebral hypoperfusion in untreated DKA, and then during treatment we have sort of vasogenic edema. And so along the way we started to get some clues that we were perhaps not right about this. And so as we've gone along, there was a real call to understand what was happening. So in 2018, Cooperman published his influential study called Fluid. And this study was a multi-center randomized trial. It occurred in tertiary care peds Emerge departments in the US. And groups were divided between rapid and slow infusion rates of fluid, and then further subdivided between 0.5, 0.45, and 0.9% normal saline. And altogether, they were able to recruit almost 1,400 children with DKA. And the management was the same for all of these in the beginning. So every one of these kids got a 10 cc per kilo normal saline bolus over 30 minutes. And the groups were divided into two categories, either slow or fast. The slow saw the replacement of the deficit and maintenance evenly over 48 hours, and the faster group had the fluid replaced more quickly, certainly within the first 24 hours. So it's interesting what this study showed. There was actually no difference in outcomes between those groups. And so the interpretation from this work is that we can use more fluid. We can use it more quickly in the past, but not adult amounts. And so this is not a call for wide open fluids in pediatric DKA, but it's for the safe, controlled, but a little bit more liberal fluid administration that we've used in the past. And so the protocol that we've adopted in Nova Scotia has been based on the TREC protocol, which is being used across Canada. And I think what is first and foremost in this diagram is a focus on the assessment of cerebral edema. And every other management decision changes based on that. And we're using the Glasgow Coma Scale, or GCS, as a proxy for cerebral edema, which has been well validated in research studies. And if the GCS is less than 14, those kids are managed differently. And so big take-home message, the assessment and repeated assessment of cerebral edema is really important because it will impact the care of these patients.
So just on the slide there that you can see the algorithm that we're using. So we're going to try to sum that all up and put it all together.
And one of the things that we'll note with the new DKA algorithm that's been used in Nova Scotia Health Authority is there is a pre-printed order, and on this pre-printed order you'll find this algorithm that's primarily aimed at emergency department use. And there's a second algorithm on the back aimed at ongoing care for inpatient pediatric care elsewhere in the province. And what we're really trying to do with this is keep the documentation streamlined. It's one patient, and the medical record and the orders will actually start and emerge and follow the patient throughout their care.
And to speak to that as well, it also comes with the emerge orders specifically, which rolls into the ongoing order. So it starts with a DKA algorithm, and then a reverse would be the ongoing algorithm for floor care. And it would be the emergency room orders, which would roll into the ongoing orders for that patient that is in DKA, that is in your department longer. It will transition through, and it'll follow the patient up to the floor as well. And there's also a trending record at the end of the packet as well, which will follow the patient, which just trends the glucose for increases and drops, as well as the anion gap and the corrected sodium. So starting with just triage process and care for a patient with suspected DKA. And triage, we don't know, we're suspecting. Like I said, if they have those risk factors or any suspicion at all, these guys are going to be brought back immediately. At least a CTAS 2 or a CTAS 1 if they are significantly hypoperfuse and altered. You're going to go right into a room and you're going to give a good handover to that nurse that's going to be taking them over. These patients need to be one-on-one nursing care when you're able. I recognize that every facility is different, and based on numbers, it's not always possible, but to the best you can, these guys need the closest care. So a good handover from the triage, you're going to get your baseline vitals and neurostatus, blood glucose, and ketones. I recognize that not everybody has a ketone meter in their emergency department, but if it's something you have, it's definitely a great tool, especially when it comes to pediatric patients. Just because if you have a high glucose and you have low ketones, you're less worried, but if you have a high glucose and high ketones, you're more worried, so you might be more apt to initiate care sooner. Accurate weights are very important because everything is based on kilo. Whether you have to weigh the patient in the mom's arms and then just weigh the mom, whatever you need to do, make sure you have an accurate weight, collect a urine, and everything that you do is going to be entered as stat. So if you're the receiving nurse in the room and you receive the handover from the triage, you're going to do your initial assessment, get these kids on a cardiac monitor, neurovitals. If they're hypoperfused or any signs of shock, don't forget about throwing on a non-rebreather. I know personally, like sometimes it's something I have to remind myself. It's an easy task that we can do that helps with the patient. So just thinking of that non-rebreather in those cases. And when you are going for IV access, where some places are doing this already, and we personally are trying to really push for 2 sites just because patients and parents, one of their biggest concerns and experience recollections is how many times their child was poked. So if we could put in one IV that was just a hub, so there's not a lot of waste, you could do your blood draws off of that IV. And then with your second IV, you could have a 2-way connector, which would allow you to have one of those lines specifically for your insulin infusion, and then one for your IV fluid and plus or minus any other medications if you needed to. The hourly blood work with your glucose, lights, gas, urea, creatinine, and osmo, like I said, could be done off that hub, and which kind of gives you as a nurse a bit more control to make sure things are done in a timely fashion. Because if you enter it for the lab, you know, they might not come exactly on the hour, and then the turnaround time for them to get back to the lab and process it. We're also going to do a urine Don't forget also about pregnancy urine and those older kids. And then obviously we're always going to consider other investigations if there's a fever, if we need to do blood cultures, any further investigations, and a baseline cardiogram for these kids in DKA if they were to deteriorate or things were to change, or an abnormal potassium. So the early nursing management, closely monitor these guys. So as a nurse that's ideally one-to-one with his patient, have a nice graph trending with your flow sheet trending your labs, so you are aware of your increases and decreases in your infusions and your patient's sugar level. Continuous monitoring, cardiogram. Don't forget, a lot of kids now, even when they're a lot younger, so we're seeing kids that are probably like 7 or 8 years old that are able to use pumps at home. So just asking those questions, and if they have a pump, making sure you stop it. NPO, bed rest, and early IV access on those kids that you're really suspicious that are in DKA. And we're still rehydrating cautiously. So we're not going from one extreme completely to the other. We're just kind of bridging the gap with a little bit more fluid. So once you have your patient settled and you have your IV and your lab sent, your next step is, are there signs of cerebral edema? So is the GCS alters? Are they irritable? The parents are a great tool for this. And then obviously for Cushing's triad, those patients are quite unwell with the low BP, low heart rate. High BP, low heart rate, low respiratory rate. So when you look at the algorithm, when you suspect there's signs of cerebral edema, you're going to go right. And if you suspect there's no sign, so they're active with a normal GCS, you're going to go down. So I'm going to just discuss to the right. So you have a kid who has an altered GCS, has like any signs of Cushing triad, the high BP, low heart rate, low respiratory rate. You're going to go to the right of our algorithm, which is going to show you have suspected cerebral injury. Clinically, like presentation developed within the first 12 to 24 hours of treatment. There's multiple risk factors. The parents definitely are your best tool. They know their child best. So the thing with kids, I would say, is it fluctuates so much in kids that frequent reassessments and asking the parents is going to be very helpful for you as the nurse and for the physician as well. So when you do suspect cerebral edema, they're going to be in
Attention,
your
please.
trauma
Tammy
room.
Carr, please return to your department. Tammy Carr, please return to your department.
When you suspect cerebral edema, these guys are going to be in the trauma room if you're able to. The head of the bed is going to be up 30 degrees. So if hypoperfused, so tachycardic, delayed refill, cool extremities, you're going to still give a 10 ml per kilo bolus, and it's going to be over 30 minutes. After the 30 minutes, you're going to do another full assessment of your patient and repeat another 10 cc per kilo bolus over 30 minutes. The key there is it's not a 20 ml bolus over an hour, it's 10 over 30, and that crucial reassessment, because we want to know if things are changing. So where the actual management changes from a fluid perspective will be your TFI. So you'll see a rehydration table in the bottom left of the algorithm. And with that, you're going to drop your TFI to 60%. So that's where you see the decrease in the fluid for this population. And then obviously in discussion, consultation with your physician, pediatrician, plus or minus 3% saline or mannitol. These kids rarely get CTs. We don't expect that any of them are going to get CTs, especially prior to transfer if they're unwell enough to be transferred to our facility. The insulin is still going to start after that first hour of rehydration.
And I think if you do have a patient that you're worried about cerebral edema, I would put another plug-in for calling the Lifeline team. I think that protocols are excellent for the average patient. Having cerebral edema is a complication, and it's important that you get advice from an intensivist early on because these patients may require individualized care. So there's things that we can expect at the bedside. There's advice that you can anticipate getting, but an early call to life flight if you've got somebody that's sick would be well advised.
And our team can perform a lot of the therapy en route as well, whereas an ambulance transfer would not be able to provide the same care. So just, again, to reiterate the nursing considerations, bed rest, we're keeping the head of the bed up. The TFI is where you see the decrease, so to the 60%, plus or minus your hypertonic and mannitol if you need it. The frequent reassessments and monitoring cannot be stressed enough. And like I said, CT is not required prior to transfer. And preparation for mannitol and 3%, you're going to follow your formulary. But you could also, in an emergency situation, use your Broslo tape, and they're given as a weight-based per kilo. So step 3.
So just looking back at the regular diagram, hopefully these guys have been triaged, they're being monitored appropriately, you've done a really good assessment for altered level of consciousness. And if they have a normal GCS, which is defined as 14 or 15, the next step for your patient is to get a 10 cc per kilo normal saline bolus over 30 minutes. And we expect a maximum of 1 liter. And then you're going to reassess your patient again. And again, looking for signs of cerebral injury, looking for signs, of hypoperfusion. If they still have persistent hypoperfusion, which many will, they can receive a second 10 cc per kilo bolus over 30 minutes. And so those are the kind of initial steps, and that is something different than we've recommended in the past. Once those initial fluid boluses are complete, again in a patient who has no altered level of consciousness, there are some new recommendations for rehydration fluids. This is not something that I'm going to memorize. The rehydration table is outlined really clearly on the Trek protocol, and it's by weight based. And so, for example, for a 10 to 20 kilo patient, they'll be receiving 6 mils per kilo per hour as a TFI, and that will help replace fluids over a reasonable time period as we go along. And so what you'll notice so far, we've done a great assessment for level of consciousness. We've given 2 boluses. We've made a decision about our rehydration. And you'll notice it is at this point that we finally begin insulin. There's no rush to begin insulin. And in particular, we recommend against boluses of insulin. We want a slow, controlled process to occur here. And when you begin insulin, you can begin at 0.05 to 0.1 units per kilo per hour with a maximum of 5 units per hour. So again, we're looking for a slow, steady decrease in things as you go along. Eventually what will happen with these kids, so they've got fluid on board, they've got their insulin on board, the glucose will eventually start to fall. And if it decreases by more than 5 millimoles per hour, you really need to start thinking about changing your IV solution from normal saline to D10 normal saline as you go along.
I think that slide just reiterates we don't want to see more than a 10 drop in the first hour.
And so this really reiterates some of these things. Taking care of a patient with pediatric DKA is time intensive. It requires fastidious nursing care at the bedside. And there are many fluid changes as you go along. We know that potassium is an issue with DKA, and so once the patient has voided and when you are certain from your lab that the potassium is less than 5 millimoles per liter, it's at that point that you're going to add KCl into your IV fluid, and we recommend adding 40 millimoles per liter into the IV solution that you have running.
So the insulin is going to start after that first hour of fluid. There's no change, like Shannon said, in the dosing, so we're starting at 0.5 to 0.1. But what has changed for us, and it may be different for different facilities, is we were using 0.1 units per mil, and now we've completely switched and we use smart pumps and syringe pumps to 1 unit per mil. So it could be what you already do, or this could be new to you as well. So how we used to do our solutions was at 0.5. So we would add 50 units into a 500 ml bag to give us the 0.1. So now we are adding 50 units into the 50 ml bag to give us the 1-to-1. So it just depends on what facility you're at and what you're using. If you're still using, the facility we're at today actually is using the 100 ml bag. So if you're using a large volume pump, you need to prime that binding site. So the long part of the large volume, every port has binding sites. So if you don't waste 50 mils of the solution, you don't bind all the insulin saturating sites. So if you're using the 100 ml bag, you need to waste the 50 mils of it, unfortunately, to prime the sites. If you're able to use a syringe, which is what we do, and we add the 50 units to the 50 mils in our big syringe on the syringe pump, we just prime the syringe with the 1 mil as you would, but 1 extra mil. There's no ports on the syringe line, so there's no binding sites that you have to worry about. All of our insulin infusions are double checked, clearly labeled. I highlight the lines, just making sure it's appropriate for that patient as well. So you're going to have to follow your site-specific policies on what you use, but we have also, and Canada-wide has transitioned to the 1 unit per mil. So whether you're using a large volume or a syringe pump. This is what I was saying when we say a two-way connector for the IV. So you can see on the red, that would be the insulin is what we're demonstrating that as. And then on the clear line, that would be for your maintenance, so for your TFI fluids. So when you look at this video, it just gives you a brief idea. So this would be your regular large volume set, and if you adapted it to the port, so the red is your insulin, clearly labeled. When you start your insulin, there we go. So when you start your insulin infusion, you can just see it's got a bit of room to go before it reaches your patient. Your main fluid line will carry that insulin in, but you have to think if you have to give any antibiotics or any other medications, then everything is going to be mixing in that one general area. And what we used to run where we did the lower concentration, we would run 20 mils. Now it's going to look like 2 mils per hour. So it's also a much smaller volume if you were using the other concentration prior. So when you look at it with the two-way, where's that video gone, Shannon? So this is the two-way. It's not clear. Sorry, it's not very clear for some reason. So you can see the insulin there to the patient. The two-way line, you can see the red. So as soon as I start it, there we go. As soon as you start the insulin, it hits your patient. And then you have your secondary line that you can run your TFI, and you could give your medications and not worry about things mixing all together. So if you're able to use those at your site, they're definitely an effective way to differentiate the two lines, and it's also good for that other double check. So just a couple of further considerations is hourly blood work and glucose. And like we said, if you have the ketone meter, that's great, and you can trend those as well. And if you were able to have the second IV for your blood work. So act quickly on lab changes. We don't want to see the sugar drop quick. We want to gradually correct these guys. So if it drops more than 5, you're looking at adding a D10. If it drops more than 10, we're really concerned about that drop. That's a big shift. So that close neurological observation is key because cerebral edema, 12 to 24 hours, is high risk. Advise the patient if they're able to report any headache or changes in how they're feeling, but also, again, use your parents because in the younger population, they are a great resource for the patient's level of consciousness and their behavior. Strict in and outs. When it comes to Foley caths, a lot of people ask, like, when do you put in a Foley? It's definitely a difficult thing for a pediatric patient to tolerate. So that would be more of our sicker population. If they were to the right in that cerebral edema risk category, we would definitely put a Foley in them. It just depends on their level of how alert they are and if they're able to, use a urinal or use a bedpan. And obviously the younger kids are just going to be in diapers anyway, but communication is key. When you're worried, make sure you let somebody know because things fluctuate so frequently with these little guys. And I'm just going to try to sum up the algorithm, which is it's accessible to them on the Trek website. And you can also get it through the IWK if anybody needed any resources, we're happy to send them. And basically, to sum it up from a nursing perspective, when you have a patient that you're worried about in DKA, you're going to obviously place them in a room, the close observations, your 2 IVs, plus or minus your non-rebreather, thinking of further investigations if required, but then again, that crucial cerebral edema risk assessment. If they meet that and you're worried, you're going to the right, the head of the bed is going up, you're still going to give the 10 cc bolus over a half hour, reevaluate, give the second 10 cc per kilo bolus, plus or minus mannitol or hypertonic at the discretion of the physician, and then you would start your insulin and your TFI at that second, after your first hour, and it would be 60% is the key. So the rehydration table, 60% of that. And if you are not worried about cerebral edema, again, they are still going to get the bolus. So basically, everybody is going to get the 10 cc per kilo bolus with that crucial reevaluation at the 30 minutes. But if they're not, there's no concern, they're not tachycardic, they're not hypoperfused, there's no cerebral edema risk, you might, after that first 10 cc per kilo bolus, then initiate your TFI for the 30 minutes until you reach that point where you initiate your insulin. But most people also ask, why can't you just give the 20 mils per kilo over the hour? And again, the key is that reassessment at the 30-minute mark. And switch.
So just to sum things up, I think Krystal did a great job of going through that. What we really want you to remember at the end of the day is that the assessment for cerebral edema is very important. that the level of consciousness can fluctuate over time, and so that neurological assessment needs to be done repetitively. The second piece of things is that the big change is that there is a 10 cc per kilo controlled bolus initially for all, so we are not advocating for wild amounts or adult amounts of fluid, so it's still a very controlled thing. Having a protocol easily available will ensure consistent and best care for these children, but we are well aware that there are children on the sicker end of the spectrum that may require individualized care. And so certainly for people whose pH is very low, so less than 7.1, who have any altered level of consciousness, who have other comorbidities, who may be at the very young age of the age spectrum, they may require different advice, and we'd encourage you to reach out to LifeFlight if they're very sick. And the other two resources are the endocrinology team and the Emerge team at the IWK. We're always happy to give advice for these little ones along the way. Thank you.
Thanks.
All right, so we'll trim up the video.
I totally messed up in there.
No,
No,
you were
I did
really
the Cushing
good.
triad. I'm like, I know
because
that.
the
arrows
graphics
were off, I know.
But then you caught it.
Oh, yeah.
Yeah,
Yeah.
still.
I'm just gonna call Julie.
Something I know in my sleep. So.
I know.
It's just because I was reading.
Yeah, those were really messed up things. I think I would prefer this one be posted as compared to the real one that we did today, don't you? Like,
Oh,
Can you show
100%.
us like
It's
a
much
clip of
better.
what it looks like?
Of the other one, I'm just going to call Julie so we can end this one, and then I'll go into the other one.
I think I hit all the key points in there. I was trying to.
I think we did.
Oh yeah, and
The inside was
so I'm
clear
going to end
it was
now.
so broad when you don't know.
I
You just say,
just
what do you
hit
guys
end,
do?
right? If
Yeah.
So I said the 100 ml bag, the 500 ml bag.
Well, we don't know.